Good evening, everyone. My name is Carol, Sunnybrook's Board of Directors, and it's my pleasure to welcome you to tonight's speaker series. These public lecture forums are a great way for us to connect and engage with you, our patients, and communities with extremely relevant and timely health information. Tonight's lecture is about understanding your skin. Lives, it's very easy to take our skin for granted. But our skin is a big deal, literally. It is the largest organ in the body and serves such a vital function in protecting us. Learning about our skin can be a great way to start making changes that may benefit us in the long run. Just one example, I happen to be a new grandmother of twins, 4 twins, and in our house, there's lots of discussion on the benefits of skin-to-skin contact. There's a growing body of evidence that shows it can really help calm and relax both parents and babies, regulate the baby's heart rate, etc. So again, just another great thing that the skin can. Tonight, we have 3 of our leading experts from the Division of Dermatology who will be sharing some of their knowledge and answering your questions. As always, we're very pleased to continue delivering our speaker series to you in our online format, and we sincerely hope you find tonight's to be interesting and meaningful to you. I would now like to introduce tonight's moderator, Dr. Perla Lansing. Dr. Lansing, the Division of Dermatology. She is an assistant professor and full staff dermatologist in the Division of Dermatology at the University of Toronto. She has special interest in pediatric and adolescent dermatology, having years of fellowship in pediatric dermatology at the Hospital for Sick Children. Here at Sunnybrook, she sees general medicine dermatology patients and dermatology clinic. So thank you so much for moderating, Dr. Lansing, and I am going to pass the mic over to you.
Thank you so much, Carol. It is indeed our pleasure to be here tonight. Thank you for mentioning that the skin is the largest organ of the body. It is the thing that separates our internal environment from the external environment. And so, you know, in dermatology, we feel that the skin is the most vital organ. Of course, we're biased, but it does have a very, very important function in our health. I'd like to thank everyone for joining us virtually this evening. We are really looking forward to sharing some of our thoughts, some talks, and some of our knowledge with you. We are indeed very pleased to have my 2 excellent colleagues with me this evening to speak to this speaker series on topics that have been highly requested in the past few months. And tonight, our lecture or our speaker series is entitled Understanding Your Skin. There are going to be 3 of us speaking tonight. Unfortunately, one of my colleagues had a very, very, very important matter to attend to today and couldn't be here. But our first speaker is going to be Dr. Joel De Coven. I will introduce him later. His talk is titled, Don't Touch Anything or You Will Get a Rash. I will be going next, and instead of Dr. Tran, I will be going next and I'll be speaking about vitamins, etc., and your skin. And then our third speaker, who will wrap up the evening, is Dr. Trevor Champagne, who will be telling us about what's new in digital dermatology. Virtual medicine and AI is a very big field nowadays in medicine, and especially in dermatology. So Dr. Trevor Champagne is going to be talking about that. Now, at the end of the 3 talks, we will have some time at the end of the 3 talks for some questions for you to ask our panel here. And thank you to everyone who's already submitted questions online, and please continue to submit your questions through the website. I'm going to preface the question and answer portion, though, by saying we cannot answer specific questions about treatments or treatment suggestions for diseases. We are here to answer general questions specifically about the topics that we're going to be talking about tonight, and maybe some general questions about dermatology and skincare, but we cannot answer specific questions about treatment options. And also, due to the interest of time, we may not be able to get to every question, but we'll do our best to answer as many as we can. So we will begin our speaker series tonight. To begin our event, I'd like to introduce you to our first speaker, Dr. Joel De Coven. Dr. De Coven is a consultant dermatologist here at Sunnybrook. He has been here many, many years and was a program director of the residency program in dermatology for several years in the past. He is an associate professor in the Department of Medicine at the University of Toronto, and his clinical interest focuses on the diagnosis and management of allergic contact dermatitis and the evaluation of complex allergic and work-related skin diseases. Dr. De Coven is an allergic contact dermatitis expert, not just in Canada, but also in North America and the world, and he has published a lot on this particular topic. We're very, very excited. He's also an amazing speaker, always very dynamic, and we're very excited to hear from you tonight, Joel. So thank you and welcome, and I will give the floor to you.
Thanks, Perla. I'm going to be just finding of course, it never works when you're looking for your stuff on there. Oh my gosh. I had it right on and it's not working. Perla, do you want to go first, and I'll see what's happening, because I have it on my desktop, but it's not showing when I'm on there.
Yeah, for sure. I can go first.
Oh, no, I have it. I'm good.
Okay, found it?
Sorry
Great.
about that. Yeah. All right. And we'll just go back to the beginning and go from there. Sorry about that, guys. And am I still sharing screen?
No, your share screen ended.
All right, we're all set.
All right.
I gotta get to my first slide. You know what? Why don't you go ahead and then I'll fix it up. Sorry.
Sure. Yeah, no problem. If you want to end there you go. I will go first. All right. So good evening. Again, my name is Perla Lansang, and I am the head of Sunnybrook Dermatology for our division. I would like to acknowledge Dr. Kusipon, who's one of my colleagues. This talk actually is mostly hers, and my special interests are pregnancy dermatology and pediatric dermatology and adolescent dermatology. And I thought this particular topic of vitamins, etc., for your skin would be much more enjoyable for our speaker series tonight. So thank you to her for sending these slides my way. I really like this picture because there are so many skincare products out there that promise to be hope in a jar. And so tonight, really, what I'd like to speak about is talk about some vitamins that might be in products that you can find in shelves, and maybe some acids that you can find in your shelves that, and speak to how which ones are helpful and how they can be helpful for your skin. So I have no disclosures to share for this particular talk. So where we are really coming from is, so when we're talking about photoaging or the damage that the environment and UV radiation can do for your skin, there's really kind of two main areas that are very, very well studied. So sun protection, or protection from photoaging, is really in the form of sunscreen, sun protective clothing, sun safety advice. So that's where we are here to protect your skin. And then once the photoaging is there's really very, very well documented interventions that we can do to correct some of this damage that's done by photoaging, like Botox, injectable fillers, lasers, surgery. But what do we do in the middle. How do we protect our skin so that we don't have to correct for the photoaging? And this is where a huge set of topical products are called cosmeceuticals. And cosmeceuticals are marketed really to prevent the photoaging so that you don't have to correct that later on. Now, there's thousands and thousands and thousands of cosmeceuticals out there. So hopefully with this talk tonight, we can narrow down your choices so you can make smarter decisions when you're choosing skincare products for yourself. So tonight, I'm going to be talking about vitamins, and not oral vitamins, not vitamin supplements. These are vitamins that are in particular skincare products or topical products that you can put on your skin. And the second part of my talk is going to be about hydroxy acids, because these hydroxy acids, so AHA stands for alpha hydroxy acid and BHA stands for beta hydroxy acid. These acids are also very common ingredients in some skincare products. So I talked a little bit about cosmeceuticals, and just from the name, they're cosmetics and pharmaceuticals. They kind of straddle the two worlds. So these are products that are topically applied, meaning you apply them to your skin and claim to reduce signs of aging or maintain a youthful appearance. So they fall between actual drugs or actual pharmaceutical products and cosmetics like makeup. And because they are not actual pharmaceutical products, they do not need government regulation, meaning they're not subject to FDA or Health Canada review. And that's why there are thousands and thousands of cosmeceuticals out there. Now, the more reliable cosmeceuticals will undergo testing to determine safety, but testing of claims are not mandatory. So it's difficult because out of the thousands of products out there, not all of them will have very good studies or data or science behind them. A lot of them are just marketing. And so we're hoping that by giving you some of the information that this talk will give you tonight, it'll help you make smarter choices. So I'm going to start with the vitamins. And again, these are not, the vitamin supplements that you can get in jars or in bottles. These are vitamins that are found in topical products in your skin. So I'm going to start with the biggest group, which is the vitamin A derivatives. And so vitamin A derivatives are also called retinoids. And retinoids are natural or synthetic derivatives of vitamin A. So it's not like you open a vitamin A capsule and put that on your skin. Retinoids are derivatives of vitamin A, but they're not actual vitamin A. And there are some retinoids that are found in prescription products like tretinoin, adapalene, tazarotene, bexarotene. So there are specific retinoids that we prescribe, and these retinoids are used for things like acne. But then there are also some over-the-counter retinoid products. So the most common active ingredients are retinol esters, retinol, which is probably the most popular one, and retinol aldehyde. So you'll see that the names are sort of similar, but retinol and retinol aldehyde are what you can find in kind of your over-the-counter cosmeceutical products. Now, like vitamin A, the reason retinoids penetrate the skin is because they are fat-derived. And so they can penetrate the skin and they can penetrate through the sebum or the oil glands in the skin and can actually exert an effect into the skin. So retinoic acid is a prescription medication. In dermatology, there is extensive literature. Retinoic acid is something that we've been using for a long, long time, and not just for acne, but it also does have a lot of data for aging and photo damage. So retinoic acid can help with hyperpigmentation, fine lines and wrinkles, improve your skin texture and roughness, because it makes your skin turn over so that the skin looks and feels smoother. However, because of this peeling action of retinoic acid, it can be irritating. So it does limit its use in some patients, plus the fact that you do need a prescription medication, a prescription from your doctor to get on this medication. However, There are some cosmeceuticals that are derived from the same vitamin. So they're vitamin A derivatives as well. And these are products that you can get over the counter that might not be as effective as a prescription retinoid, but can still help in terms of achieving some of the effects that a retinoid will give you. So retinol and retinol aldehyde are gentler, but still effective at achieving the goals that a prescription retinoid would like to give. So a cosmeceutical or a topical product that's over the counter must contain at least 0.025% retinol or retinol aldehyde to have an effect. So certainly that's something you want to look for, not just any retinol, but something with at least a 0.025% concentration in the particular skincare product. So this is just a study to show you that retinol, so this was a 0.4% lotion, was applied to aging skin. And you can notice a significant wrinkling between the baseline here and month 6. And this is a close-up of that photo, so at baseline and month 6. So if you choose your over-the-counter retinol products wisely, you can mitigate some of the wrinkling and some of the photo aging that you can get in your skin. So retinol aldehyde is another product. It's a conversion of retinol to retinoic acid. It's an intermediate in that process. And again, you see here that retinol aldehyde can produce significant improvement in skin roughness, fine lines, and wrinkles. And it's also well tolerated, much better tolerated than the prescription retinoic acid that we normally will prescribe, because retinoic acid does cause a lot more irritation. And in fact, some patients can't tolerate the prescription retinoic acid. So those are your two retin A or vitamin A derivative products, so retinol and retinol aldehyde. If you want to find a vitamin A product that is over the counter that can help with that, with your skin. The next vitamin I'm going to be talking about is vitamin B3. And there were two forms that can potentially be used in cosmeceuticals. So the first one is nicotinic acid, but this doesn't tend to get used because it causes vasodilatation, meaning it causes a lot of flushing and redness. Therefore, this is not a vitamin B3 derivative that is used. The one that is used mostly in your cosmeceutical products is niacinamide, which is very well tolerated, stable, and relatively inexpensive to make. So you will see a lot of products with, niacinamide or vitamin B3 added in them. So what does niacinamide do for your skin? What does it do when you have that in your product? So vitamin B3 is moisturizing because it increases ceramides, which is a specific moisturizing product in your skin that improves the moisture in your skin. It improves the barrier of your skin and also minimizes the water loss from your skin. So that's the first one. The second, it reduces redness because it decreases the irritation from your environmental factors. Number 3, it can improve kind of the glow of the skin. So it improves sallowness. It inhibits protein oxidation, which leads to yellowing of skin as we get older. So it improves that. It can reduce fine lines and wrinkles by stimulating synthesis of collagen. So it enhances the making of collagen and proteins in your skin. And lastly, mildly, it can also improve pigmentation. So because it inhibits the formation or inhibits a transfer of kind of pigment from skin cell to skin cell. So these are the reasons to use a product with vitamin B3 or niacinamide. The third very popular vitamin in skincare products is vitamin C. Now, vitamin C, which is very much in our diet, is essential for life. In the olden days, when there were sailors who used to cross the seas without any fruits, they would get scurvy. And that's a deficiency of vitamin C. So vitamin C is something that we need on a day-to-day basis because it's important for a lot of functions in the skin, in our body. So in the skin, what vitamin C does is three things. One, it's an antioxidant, which means that it reduces the damage that the environment does for our skin because it helps regenerate vitamin E, which we will talk about later. Number two, it helps in vitamin C as an important cofactor when you're making collagen. So vitamin C regulates the making of collagen in your skin, and collagen makes your skin supple. It's kind of like the bulk of your skin. And number three, it can reduce pigmentation by inhibiting the formation of pigment in your skin. So vitamin C makes a lot of sense to put in your topical products. However, for vitamin C to work, you need at least a 10% concentration of ascorbic acid in order for the vitamin C to be effective. And that's important because vitamin C products are not inexpensive if they are made well. And so this is unlike the vitamin B products, which are less expensive. Vitamin C products, because they're harder to make stable, cost a little bit more, and you need a much higher concentration of vitamin C. And the makers also have to formulate it with a lower pH so that it can optimize the absorption into the skin. So vitamin C is a little bit more finicky in your skincare products, and that's why it costs a little bit more, but it does have a lot of functions in the skin. And then the last vitamin I'm going to be talking about is vitamin E, which is also an antioxidant. So what antioxidants do is they absorb some of the damage that, let's say, UV radiation will do to the skin. So it inhibits free radical formation, and it helps in the repair of your DNA. So that's what antioxidants do, and vitamin C is an antioxidant, and vitamin E is also an antioxidant. So vitamin E has a major role in photoprotection, meaning in protecting the skin against UV damage, because studies have shown that if you apply vitamin E before UV radiation, it reduces the damage caused by UV. So vitamin C and vitamin E they help with your sunscreens. So if you put them before you put on your sunscreen, it augments the photoprotection that your sunscreens will give you. Vitamin E is much less finicky. So topical preparations can range from under 1% to 20% vitamin E. However, we don't really have any good data to show us what the ideal range for vitamin E is. And oftentimes what you'll find is the vitamin E, the more effective or the better vitamin E products will have vitamin C along with it in combination with the vitamin E product as well. And that's because studies have shown that if you have a combination of a vitamin C and vitamin E, so two antioxidants together, that combination is superior to either just vitamin C alone or vitamin E alone. And so this particular product that was tested was 15% vitamin C or ascorbic acid and a 1% vitamin E combination. And that combination provided a four-fold protection compared with, no vitamins in UV-induced damage. And so vitamin C and vitamin E work synergistically because vitamin C helps vitamin E to regenerate, and both products are very good antioxidants to help guard or to help your skin recover from UV damage and free radicals. So that takes me to the end of the vitamins, and the next components of cosmeceuticals that I'm going to be talking about are the hydroxy acids. And the hydroxy acids really function to kind of peel your skin or make your skin turn over more efficiently, and they do it through different ways. So the first big group are the alpha hydroxy acids. And there's various examples of this. Glycolic acid is a very popular alpha hydroxy acid. So if you look through some of the cosmeceuticals, they will have glycolic acid. Some cosmeceuticals will have lactic acid. So those two are probably the most common ones, glycolic and lactic acid. But you have other citric acid, malic acid, pyruvic acid, and tartaric acid. And what alpha hydroxy acids do is they exfoliate your skin. So they make your skin peel in kind of a microscopic level. You're not going to get visible sloughing of the skin, but that is really the goal of using an alpha hydroxy acid on your skin. And so what that means is that if you have skin that is very scaly or very thick or very rough, it can help improve the texture of that particular skin. Also, thinner epidermis or smoother skin reflects light better. And so when you're using these products to help with the texture of your skin, the skin also appears smoother and more uniform because it reflects light better. So again, these products are used in the treatment of rough, dry skin and also mild wrinkling and photo damage of the skin. And because they cause the skin to peel, they are often used in addition to other products to improve pigmentation changes as well, because they help peel the skin. And then the last group of products are beta hydroxy acids, and the biggest group or the most common and the most popular one by far is salicylic acid. So salicylic acid, it's usually what's used in a lot of acne products. And salicylic has the advantage, the reason it's used in acne products is it can penetrate the sebum or the oil of our skin to penetrate into the hair follicles. And it's really in the hair follicles where acne starts. And that's why using salicylic acid in an acne medication often helps improve, the whiteheads and the blackheads that you can get with your acne medications. So that is the function of beta hydroxy acids. And with that, I'm going to end this particular session. And I hope you found, the information about the vitamins that we can use and the acids that we can use on our skin interesting and useful. So the next time you go to a cosmeceutical counter, maybe you'll be able to read things and understand things more. Thank you very much. And so I think we'll go to the question and answer portion at the end. I will turn it over to Dr. De Coven now. And he will talk about things that you can touch that can give you a rash.
In other words, don't touch anything. We see many people at Sunnybrook Dermatology, and many of the people that we see are itchy and they have a rash. Some people think they're allergic to something. Some people think it might be food that they're eating. Their doctor may think they're allergic to something, or our patients may have no idea that they're allergic to something. No matter what, we try to find an answer. And we'll find an answer for different types of individuals. So this poor person who came through the emergency department with a reaction on her face and around her eyes. Or this individual who has put up with a chronic rash on his abdomen for many months, not knowing what's going on. And this man who has a persistent rash just on his left hand and can't figure out what's going on. So these are the types of people that we might see at Sunnybrook. Now it gets easy. If someone comes in with an allergy lotion, we know what's causing the allergy, but people don't come in quite like that. And then we have to put the puzzle together. And sometimes it's not obvious, but once we learn how to do it, it becomes obvious. So we put the puzzle together, and now we know what's going on with the patient. I deal a lot with contact dermatitis or contact eczema. And that simply is inflammation of the skin, which can present with redness, blisters, itchiness, or dryness. And it's caused by an interaction of the chemical with the skin. And it may be due to irritation or allergy. So if you have someone who dips their hands in something that they shouldn't dip their hands in, quite immediately, they're going to get a reaction like this. And this is simply an acute irritation. But when we have an allergy, this involves the immune system. So our immune system is directly interacting with a chemical, and it's chemical specific. And typically this is a delayed reaction after exposure. So it may occur 4, 6, 8, 10, 12, 24 hours after exposure, as opposed to a couple of minutes after exposure. When do we suspect that someone may have a contact allergy? They may have had several episodes of their skin blowing up or having dermatitis or eczema. Or they may have had a bit of a condition and then all of a sudden it flared. Or we would expect that their condition would respond to treatment, but it just isn't responding. And then there's certain occupations that we may think of, for example, automotive technicians, nail estheticians, etc., which will raise our suspicion that we could be dealing with allergic contact dermatitis. So what we try to do is we try to figure out who has a contact allergy, find out what may be causing it, make sure that the people that we see know what they have to avoid, what they can use, and then also treat the condition. Some people have certain fallacies. So they think that expensive hypoallergenic products are best. So I'm an iconoclast, and I'm here to tell you that there's no such thing as hypoallergenic in Canada or the United States. It means nothing. There's no regulations that govern it. Now, what does dermatologist tested mean? I like to joke that I'm wearing 30 different products right now as I'm speaking, and that's how I'm dermatologist testing it, because there's no such thing as dermatologist tested. Some people think you have to have an allergy only if you tried something new, and you can develop an allergy to something that's you've been using for years. And they think that you have to have an allergy within a couple of minutes and contacting it, as I told you, could take 4, 6, 8, 10, 12, 24 hours. They also think that you'll only have a reaction at the site of exposure, and you could transfer an allergen from your hand, for example, onto your face and have a problem with your face. And also people say, well, I only used a little bit of this and it's not dose dependent. So you could be exposed to a small amount, but if you're really allergic, you're going to react to it. So this is how we find out what's causing the problem. We do something called patch testing, and it doesn't involve any needles. So we have a whole array of trays of different chemicals that we can test people to, that we keep in our nice handy fridge. And they're laid out into little strips of 10 that we put on someone's back. And so they're put on the back, let's say on a Monday, and then the patient comes back on a Wednesday after having worn this for 48 hours. And this is nicely taped into place to leave it secure. So when they come back, we take all those tapes off, and then we see if there's any red reactions. And then they come back again 48 hours later on the Friday. And then we look to see if there's any delayed reaction. What might be we see? We may see a mild reaction like this, or they may have a moderately positive reaction, or unfortunately, sometimes they may have a very severe reaction to the patches. They're all numbered, so we know what each substance is, so we can advise our patients. Then we have to correlate the test results with exposure. So just because someone has reacted positively does not necessarily mean that it's the cause of the rash. We have to have a definite exposure that has that chemical in order to say that perhaps this was the cause of their problem. And was it the main cause of their problem, or did they have some rash and they used something on the rash and it was a secondary cause of their problem? After we figured some of that out, we'll identify for someone, this is the name of your allergen. Here are the other names that you may see on labels. This is what's going to happen if you're exposed to it. This is how you can be exposed to it in the many ways that you could, and how you avoid exposure. So after we've tested someone, it doesn't necessarily end there, because we can't test every single substance that's on the market. So someone can do what's called a repeat open application test, take a cream or a lotion that they may want to use, put it just below the crease of their elbow twice a day for 2 weeks, and we see if there's a positive reaction. And that way you can troubleshoot many of your own products. But this sometimes can be negative. So then we say, do a serial usage test. And that means you've passed this test, but then you put it on your skin. And this is a patient of mine that gave me this picture. And she tried it on the side of her face after passing the first test, and she developed a rash. So this is a positive usage test. So let's translate theory into practice and see what types of situations we may find in the clinic. So this is something that we used to see a lot, a little child with this interesting pattern on the chest representing an allergy to nickel in metal buttons on her sleeper. This is one of my favorites of hoop earrings, where you notice the red spot on her neck, and she was developing that because she was allergic to the hoop earring, and when she turned, it would touch her neck. Another fave, what I like to call toilet roll earrings. So some people have the facility of knowing just how far they can stretch the earlobe without having that permanently distorted. But you can react to the metal or the rubber in these earrings and have an allergic contact dermatitis. This gentleman, who you may remember from before, ended up having a positive reaction to nickel in his belt buckle. And if you look at the underwear, if you can read that, you'll see that nickel allergy, thankfully, still exists in the future. My computer can cause a problem. So the metal on my MacBook Pro with a hand dermatitis and little bubbles, and then we can test to see if there's enough nickel in it with a special solution that turns pink on a Q-tip when we rub it against the metal. And this means there's a lot of nickel that you can react to. Here's a patient of mine who would have a normal arm, and then after doing a certain type of activity, would develop this problem on the crease of her arm. So we patch tested her and she was positive to both nickel and cobalt. Well, she had a favorite activity that she liked to do. And what she would do is, she was a pole acrobat and she would wrap her arms and legs around the pole. She was allergic to the nickel plating in the pole and developed the problems at the crease of her elbows and behind her legs. Sometimes the diagnosis is still up in the air. And here's how she presented about 6 hours after she'd be on the pole. Fragrance is another common thing that we see people react to, and it may be in their cosmetics or their skincare or hair care products. Cleaning products and laundry products may also include fragrance. There's a patient that I saw in the clinic who looked like she had a bad cold, and she was referred to me for possible allergy testing. And so you can see the redness of her nose, you can see the redness around her mouth. And then I noticed when I was looking at her, she had this on her baby finger. I said, wait a second, what's going on with your finger? And she said, oh yeah, well, I sometimes use that for things. I said, well, what do you use it for? And so she used this particular product, and in the product label, we can see there's lots and lots of fragrance. So she would take the product, which had essential oils as well, and she'd put it on the end of her fingertip, the baby finger, and she'd put it into her nose and all around her nose. And she was allergic to all of those ingredients. Case solved. So now we get to essential oils. And in my world, I like to call them essential allergens. And these are botanical extracts that many of you will be familiar with. They're concentrated, distilled substances. And there's absolutely no formal regulation or standardization process. So it's buyer beware, caveat emptor. And here's some examples of essential oils. Two of the most common, tea tree oil and lavender, but we'll have ylang ylang, peppermint, lemongrass, sandalwood, frankincense. There's lots of essential oils out there. And it can also be used as an air freshener in diffusers, just like a cool mist on a summer evening. Bathing and hair care products, massage, skincare treatments. And these things can cause quite the rash. So here's a patient of mine who had a little bit of a rash on the shoulder, but then developed a problem on the hand and then on the arm. And so some of the common individuals that we see with this are women who are using it on their face or neck, or poor children who are treated with this by their parents because they think it has health benefits. So this is something that we're seeing more and more, allergic contact dermatitis to essential oils. No one can imagine the sheer joy that takes place every day right across North America from people coloring their hair. But sometimes, somewhere, it can result in disaster. And you'll remember this person that I showed you at the beginning of the talk, and she had a horrible reaction to hair dye. This is not atypical for some people. And what's also is not atypical, that someone will say to me, the third time this happened to me, I decided I better check it out and find out what's going on. This is how badly people want to dye their hair in society. And it's not just confined to women. So here's a patient of mine, a man, and you can see the pattern here all along the hairline. and one of the telltale signs at the top of the ear as well. These are the types of reactions that you can have from hair dye allergy on our patch testing. A gentleman who developed a problem on his face, he was very meticulous, put a cream on to try to take care of it. The rash seemed to get a little worse. He spread the cream a little bit more, got a little worse, spread it a little more, making sure it was right where he was having the problem. And what was going on? He was allergic to his polysporin. So I want to scare you guys from using polysporin antibiotic ointment. Here's a young boy who was referred to me from sick kids, and they thought he was reacting to a bandage that he had put on after he'd skinned his arm and the side of his body. But he had these patch tests, and these are ingredients in another form of polysporin. So he was allergic to his polysporin. But the coup de grace is another patient who developed a cut and had a finger like this, but then it became like this, and then like this. And here's our culprit, polysporin. And that can contain antibiotics that people are allergic to, and also local anesthetic agents like lidocaine. And this is, if you want to have a pizza finger, go ahead, use poison ivy in a tube. A gentleman who had an itch on his chest decided he was going to use something, and you'll recognize this gentleman from the beginning of the talk. It's on his left hand only, and that's because he's left-hand dominant. He's left-handed, and he was applying something onto his chest and developed this problem. And what was he using? He was using lanocaine, which has a local anesthetic called benzocaine. Again, case solved. A woman who developed a chronic dermatitis around her eyes. Now, you don't have to have a real acute weeping dermatitis to have an allergy. And so this was part of a great epidemic, if you will, of reactions to Great Lash Mascara across North America and Europe. And now that's been rectified. This is what we're up against in the clinic. I love this slide with organizing your makeup collection. This is someone who tried to pseudo-organize her makeup collection. And I'll tell you that the average man probably uses about 5 to 6 personal care products a day. And I like to joke that the average woman uses 760 products per day, and a man can only identify what 10 of them are used for. So we certainly see gender differences between people who use lots of makeup and people who don't. Gel nails, shellac nail polish. Is this getting ridiculous enough for you where you're not going to use anything? So shellac nail polish, which is applied either at home or in the salon, and then you shine an ultraviolet light on there and it cures it. So it sets, and it has very nice colors. Even I like the look of this, and it has very smooth, but you can result in this type of picture around the nails, and you can have permanent nail damage, especially with the gel nails that are built on top of your own nails. We'll see workers who are using rubber gloves and they get allergic to their gloves and have a bad dermatitis on their hands. And we can patch test them to their gloves themselves, and we can see that they're reacting to the gloves and also to individual ingredients, and find out what the individual ingredients are that they're reacting to. You have a problem with your wrist. Someone from employee health says, oh, you better use this wrist wrap. And lo and behold, you develop a problem with the neoprene wrist wrap, and you're allergic to something in the neoprene. It keeps on going. So you're wearing your clothes and it's got a certain dye in it, and you end up reacting to the liner in your pants, and you're allergic to the blue dyes. Another way you can become allergic to something. This is a classic. So we see these linear red streaks across the side of the lower torso and the extremities. And this is one way that you can have poison ivy. And so you can develop a spot on your skin, and then you develop a whole bunch of other spots, not necessarily because you've contacted the poison ivy there, but because your immune system goes on red alert and you start getting other rashes in other areas. In the more acute state, you can look like this. So lots of swelling around the eyes and oozing. Here are 3 different ways that poison ivy can look. So they can be different colors. You can have jagged leaves. And they say, leaves of 3, leave them be. So we have poison ivy. And in the poison ivy family, the same chemical can be in poison oak and poison sumac. So poison oak also has 3 leaves. Poison sumac has 9. Then we come into one-handed dermatitis. So I showed you that gentleman who had that terrible rash on his left hand. He was applying the lidocaine on his chest. And so here's someone who had a dermatitis only on one palm of the hand. It was hard to figure out, and they reacted to something called black rubber mix, which are chemicals that can be in black rubber. Well, this was not my patient. This was someone else's patient, and they actually followed this guy to work, and they couldn't figure out what was going on. But when they followed him to work, he went up on the mezzanine elevator, and this is why he was reacting to black rubber on only one hand. These are the types of puzzles you may see. Here's someone who had a red ear and was tested to a botanical array of allergens because one of my colleagues was trying to put together botanicals that they could test their patients to. And they reacted to something called lichen acid mix from lichen. So she asked this lady, what's going on? Like, why did I test you? And she said, well, I had this problem on one ear. So they talked about it and they were troubleshooting it. And it turned out that she was allergic to her husband's deodorant. Every night she would sleep with her left ear in her husband's armpit. And that's how she developed her red ear. Finally, my favorite case of a guy who had a problem with his neck. And so he had a rash on his neck, and he came up positive to a topical antibiotic, which some of you may be familiar with, Neosporin. And so the question is, oh, are you using Neosporin on your neck? And of course, the answer was, no, I'm not using Neosporin on my neck. Well, have you ever heard of Neosporin? Yeah, I've heard of Neosporin. Well, how have you heard of Neosporin? Well, I put it on my pet snake. And this is why he was having the problem with his neck. Neosporin contact dermatitis from his courtesy of his snake. So at Sunnybrook, what we try to do is figure out who has a contact allergy. Again, find out what's causing it. Make sure that people know what they have to avoid, determine what they can use, and treat the condition. So we're always looking for new allergens and new patients. And so one of my latest faves, I like to confiscate things from my patients, snake oil. Thanks for listening.
Thank you very much, Joel. That was super interesting. I always kind of look at your job as being a detective, like you're the CSI of dermatology.
So well, sometimes when I give talks, I'll have, I was talking in Newfoundland, I had Newfoundland CSI, for example. Yeah. Thanks, Carla.
I'm sure there's going to be a lot of questions, but we will save them for later. I'm going to introduce our third speaker, and our third speaker is Dr. Trevor Champagne. And Dr. Trevor Champagne is our computer and technology and artificial intelligence guru, not just in Sunnybrook Dermatology, but in all of dermatology in the University of Toronto. I think what he does is very, very unique and very special. And so he's here today to talk about, Dr. Champagne is founded the Sunnybrook Dermatology Machine Learning Lab. And so he is here to take over the world. I'm kidding. Dr. Champagne, please.
Okay. Now the fun part here will be if I can't figure out how to share my screen. Perfect. So thank you so much for that introduction. Really, like my day in and out is very immersed in technology. I was a computer science guy long before medicine, so it's really permeated everything that I do academically from there on in, and I just find it absolutely fascinating. So I do consult for some teledermatology and AI companies, but I'm not going to mention anything specific in this talk. And really what I want to talk about today is just a few common questions that come up in digital dermatology. Because like everything else, the digital and computing sphere has really started to permeate everything we do everywhere, and dermatology is no exception. You know, one of the first questions that always comes up is, what will be the future of virtual visits in dermatology once the pandemic is over, if the pandemic is over? Virtualization in dermatology is really an established practice. There's been services dating back almost 20 years looking at the use of video conferencing and pictures in order to essentially help patients not have to go see the dermatologist if they don't have to. And with the increasing number of devices like webcams, like we're using now, phones and other portable devices with reasonably good cameras, it's becoming easier and easier to build out and use these types of services for people. There's some problems though. Webcams, it's like they're really built for carrying on a conversation. So it can be really difficult to see high quality images over a webcam. This is why when everybody was kind of forced into using virtual care, everybody really moved towards a model of at least including some kind of photo in the consultation. And then with that, some kind of medium to have a conversation. And in most cases, that ended up just being the phone, partly because it was approved by the government that we could do that, and partly because webcams themselves are tough to use for people. You have to have a fast internet connection. You have to know where to click and what to click. It can be difficult to get the right audio settings, and on and on and on. So the other thing that's really come out during the pandemic is that it's, even with the cameras, it's really tough to take a good photo. There are lots of instructions online as to how to do it, photo rules to follow. So well lit, hide your distractions, open app, hold it steady with both hands, focus your photos and orient the camera correctly, all those things. A lot of them don't mention the very first thing, which is that it's incredibly difficult to take a good photo of yourself. You just can't possibly get the angles. You can't take a picture of your back without someone else there. And even the photo instructions, it's like this one just assumes that there's somebody else there to help take a photo for you. So it can be really, really finicky. The other caveat to remember with virtual consults and virtual visits is the amount of things that you're not getting from what your dermatology experience would be if you went into clinic. It's really difficult to look at pictures of the scalp and make an assessment. It's really difficult to look at places like inside the mouth. Sensitive areas are difficult to examine virtually. And for sure, you can't do full skin checks. And sometimes you don't know what you're going to see unless you see it. We have lots of special tools in clinic. We have dermatoscopes that let us take really close-up pictures of skin lesions so that we can tell very closely if they're skin cancers or not. We have things like the Woods lamp, which you shine it on something like a rash and it can tell you very quickly if there's some kind of bacteria or fungus or yeast there that would do well with treatment. You can't take swabs and you can't take clippings and all of these tests that we would otherwise do in clinic very, very quickly. You can't do in a virtual consult. And that's not to say there aren't solutions for this, because there are companies that propose, testing sites, there are add-ons for your phones, there are digital dermatoscopes, there are lots of solutions, but it's all very scattered and not very organized at this point. So really, when people say, well, what's the future of virtual consultations? The sphere of access has just completely exploded. People are accessing dermatology from home, on apps. Primary care doctors have been able to access dermatology and get really a 72-hour turnaround on consults for the last several years, funded by Ontario Telemedicine Network. Pharmacies have been suggested as places to put dermatology devices to access. Long-term care facilities benefit greatly from these types of consultations. Then you have to ask, well, what kind of devices are you going to use? Are you going to use phones, digital cameras? Are you going to use a digital dermatoscope? Are you going to use webcams? How is the consult going to happen? And really, what's the circle of care at the end? There are apps that'll let patients consult and message directly with a dermatologist, and you get a response back, and that's about it. And you're left responsible to follow up the results of that. You may follow up with your primary care. There may be integrated services. And right now, some variation of all of this exists. And it's really going to be up to us as dermatologists and patients and the greater community to decide which of these tools are helpful and in line with our societal values and have the necessary evidence base to continue their use. Because in virtual care, there's lots of evidence for everything generally, but there's very little evidence when you dig down into the specifics. So the short answer to what's going to happen to virtual care is, I don't think we're sure, but there's lots of opportunities. There's also lots of dangers. Another question we get asked a lot about is something called mole mapping, because it's a fairly old idea that originated in medical photography. And we used to have medical photography clinics where you would go to the clinic and the medical photographer would have an excellent camera, take lots of field pictures of the skin, of your back, thighs, arms, things like that, and then print out the sheets on gigantic posters to give you, and then you could take them to your appointments, and intended to use to see if we can identify new spots and see if we can identify changing spots in order to see, more likely to pick up skin cancers a little bit earlier. So mole mapping is really the extension of that idea digitally. And there's two aspects of it when you look at the literature. There's still the clinical photograph aspect. And so you get these field photographs, and a lot of the services that offer it will have these advanced algorithms, not quite artificial intelligence, because it's not really, making any decisions for you, but what it really is doing is using computer techniques to say, are there any new spots that we should take a close look at? And most modern services will also incorporate some form of digital dermatoscope into that. Now the reason is because clinical photography is great, but no matter how fantastic a resolution you get, eventually you'll zoom in and get a spot like this. And very, very difficult to tell about small kinds of changes that you would otherwise notice on a high resolution photo with a dermatoscope. And the truth is that if you can't tell the difference between these photos, then we've really, it proves my point about how bad webcam and video conferencing technology can be. There's some caveats with the service. So not every new mole that you're going to find is going to be dangerous. People are still going to get lots of wisdom spots and benign cherry angiomas and lots of things as you get older, as you get more sun exposure. So not everything is dangerous. So it's important to engage these services where a dermatologist is available to assess new lesions. One thing we're also finding out is that not every change in a mole is necessarily going to be a dangerous change. Even if it is a true mole and it's pigment and it could potentially be a melanoma, well, there are changes that happen in moles that aren't necessarily dangerous. But right now, the safest thing to do with any changing mole is to do a biopsy and excise it. And so I think it's going to be several years before we know for sure which changing moles to excise and which not. So carries a risk. Doing the mole mapping, if you're looking for things, you're going to find them. You're probably going to be exposed to more biopsies. Right now, there's a fairly high cost associated with the process too. The studies usually engage, the studies that have shown positive results, usually engage the services of kind of total body photography and comparisons and digital dermoscopy and comparisons every 6 months or so. And the cost of each session can run hundreds of dollars. Currently it's not covered by OHIP. So there can be a high cost of engaging in that. And if you're going to a service that's collecting all your data, it can be very difficult to get your data back out if you wanted to take it somewhere else. And then really we're left with the question of who benefits? Who are the right patients for this service? There are some patients who are at very high risk of skin cancer, and the safest thing for sure would be to think about engaging some kinds of services, but it's very, very difficult to tell. So the real answer to that is check with your dermatologist. And it looks like as the future goes on, there are going to be some app-based and portable solutions as well too, because you can get little digital dermatoscopes for, phones and devices that take reasonably good pictures for you to track your own skin over time, which is something we usually recommend anyway. How good it will be is also a kind of a question for the future. The last really fun thing that I want to talk about is how the idea of artificial intelligence is impacting dermatology now. And part of this really ramped up in the last, say, 5 years or so, just because dermatology has becoming more digital. There's been more images captured, lots and lots of images of skin cancer. There's an international skin classification database that has about 60,000 images of normal skin lesions and cancerous skin lesions. So one of the basic approaches that people have taken is saying, okay, well, we have these computers, algorithms, and networks that can say, look at a cat and tell you whether or not something is a cat or not a cat. Why can't we apply this to skin cancers? And so they tried it. And so a number of algorithms were developed over the last 5 years that were really just looking to try and diagnose skin cancer, diagnose types of skin cancer. And it's similar theme tonight. In terms of the cosmeceuticals, there isn't a lot of regulation for cosmeceuticals. As Dr. De Coven said, it's like there's not a lot of regulation on the terms used to describe products. And in this particular case, there is just not a lot, if any, oversight on apps that are released to the marketplace as into how well they work at actually diagnosing skin cancer. And part of the problem is that artificial intelligence is not really intelligent. It really is just a series of statistics. You put in a picture, you get back a series of numbers. And so the interpretation of those numbers is a very, very difficult question. It seems easy at first, but if you pick the wrong set of numbers, then you get a lot of wrong results. So there was a very recent study done by researchers in the EU who took some of the apps that were available and said, well, what happens if we put a combination of rare skin cancers and just benign spots together and see how the apps behave? Well, what they found is, first of all, the apps only knew what they'd been taught. So if they'd never been taught what, say, a rare Merkel cell carcinoma wasn't able to identify it at all. So 0% success rate at identifying those cancers. And you'd say, well, maybe that's okay. Maybe there's still some utility to it. But then they looked at the flip side, which was also a problem. So in order to release and get some sort of approval, often the app companies will have to go and say, well, it's safe because it will never miss any of the skin cancers that it knows. And in order to do that, it'll take benign spots and say, well, I'm just not sure, or I'm worried about this. And what they found was 65% of the benign spots that they fed to the app, it said, well, I'm not so sure about this, you should see your doctor. Which unfortunately makes the apps either dangerous or effectively useless. And the worst part is that if you're getting results where it's saying, well, I'm not so sure about this, you should see your doctor, it has the potential to waste healthcare resources and worry patients immensely. because now you have this result and it seems tangible and it seems informed. But it really is just fancy statistics telling you, well, I'm not so sure about this. You should see a dermatologist about that. So I really like this diagram because artificial intelligence in general, throughout society, goes through a gigantic wave of inflated expectations, and then we get into what we call the trough of disillusionment. So if you look, they're marking computer vision, which is what a lot of those techniques are, at really in the trough of disillusionment right now, and that's really where we are. But that's okay. It takes people to go in and discover what works and what doesn't work before we can start thinking about responsible, safe, and effective ways of using this really powerful technology. There's been some wins on, say, things like looking at genetics of melanoma. There are, upcoming genetic tests that, take these insights and take these algorithms and look and say, can we predict, how likely it is that this melanoma or this cancer is likely to spread? So there's been some good successes with that. And I think with computer vision, the field is just broadening. Maybe it's not that important to get a diagnosis from something, but if you can look at things from a triage perspective, maybe all it needs to do is tell, a virtual care dermatologist that you need to be able to look at this a little bit faster. And I think those will be the really impactful wins that we'll see over the next several years as we go forward with this really cool stuff. So that's all I have to say. Thanks very much.
Thanks, Trevor. Really, really exciting times, but I am glad to know that we're not going to be out of a job anytime soon. And that concludes the talks for this evening. We're going to do the question and answer portion, and some of you have sent questions that before the talks actually, and some of you have sent questions tonight. So I'm going to try to get through as many of them as possible. So the first question I have is for Dr. De Coven. Why would a senior adult or an older adult develop a skin rash from outdoor plants which did not occur in their younger years?
Part of that has to do with what one genetics is, so that we could have many people that could be exposed to the same thing. And genetically, some people may never react to it. Some people may react after first exposure. So you have to be exposed to it first, prime your immune system, and then react to it. And some people with repeated doses of it will have enough where it will tip their immune system and then react to it. And we don't really know all of the factors involved that determine whether someone is going to become allergic to something or not. But what we do know is they could become allergic to something at any time throughout their life. And you even see that with other things aside from contact dermatitis. So I know of people who have become peanut allergic in their late 30s, where they had no problems when they were a kid. And again, it has to do with dosing, has to do with how much exposure you have, and also your genetics.
It's true. That is a very common question that we get in clinic. Sometimes patients will ask, well, I've been using this product for 2 years. Why am I only getting an allergy to it now? Is that kind of the same kind of thought?
That's right. And again, there isn't a great explanation to go through all of the basic science of it. But suffice it to say that everyone who's become allergic to it has gone through the same process of priming their immune system to become allergic. And so why one person will recognize something as foreign where they never did before, and another person can sail through life without any allergies, we don't have that definitive answer.
It's true. And that's the thing with like an allergic contact dermatitis is it's not really a reaction to something that's necessarily bad for you, right? It's not something that's toxic, like, you know, a lot of the fragrances are not toxic, but there's something in your immune system that doesn't like it.
Yeah, and you know, just talking about fragrance, you know, my role I see is not to tell someone that they can't use anything for the rest of their life. So we have to be very careful, because on one hand, we want to identify what someone may be allergic to, but we don't want to overcall it. So in the case of fragrance, you may have someone that's allergic to a few fragrances, but there's hundreds of fragrances out there. And let's face it, lots of people enjoy fragrance. So the idea is not to take everything away, but sometimes you start with that premise and then you add things on bit by bit so that people can still enjoy their life and enjoy their fragrances and other sort of substances.
So there's a question here for me, I suppose. Can you use all these vitamins at the same time? Is there a specific routine you should follow to get the most out of these vitamins? So yes, there are products that are combinations of these vitamins, like the vitamin C and the vitamin E that I talked about. You can layer some of these, of course, being careful that you don't develop an allergy to some of these vitamins, as Dr. De Coven's talk had alluded to, because I certainly have seen contact dermatitis to vitamin E, let's say, right? In terms of a specific routine that you should follow to get the most out of these vitamins, the antioxidant vitamins work best when you're putting it on underneath your sunscreen and when you're putting that on prior to sun exposure. So the antioxidants have a lot of studies that show that they do augment or they improve the sun protection that you get from your sunscreens when you put in an antioxidant before you put on your sunscreens. So I think that would be the only timing perspective that I would put into that question.
I would add one other thing, that not all vitamin C is the same. And so, you know, there's high quality vitamin C that has undergone stability testing and efficacy testing, and then there's bogus vitamin C. So it's like anything in life, not everything is homogeneous.
Definitely. And this is why the world of, you know, cosmeceuticals is so confusing, because there's such a big range of quality and quality control among the cosmeceuticals. And that's what I was talking about when, like, really well formulated vitamin C can be a bit more expensive because it is harder to make. This is an interesting question, Dr. De Coven. Can you get an allergy from coming into contact with someone else who had a reaction to something? So I guess, is an allergy contagious? I think that's the question.
Not directly. So we have an expression, consort dermatitis. So that something could be on a friend or an intimate friend that you happen to contact. So in essence, they're a vehicle for transporting the allergen. But you know, I haven't looked at any studies of, you know, getting a blood transfusion with someone that's allergic to nickel, for example, and are you going to be transiently allergic to nickel? We also know that you can be allergic to substances from other people. So, for example, in couples where, let's say, you have one male and one female, it's certainly well described that some people can be allergic to semen. And so that's not directly that the person themselves is allergic to their semen, but someone else can be allergic to that. So the world of allergy and contact allergy can be quite complex. Now, another way that you can be exposed, let's say as a vehicle, is if you have a dog. And we've seen through COVID that it's just amazing the number of dogs that are out there. And of course, if your dog happens to trample in poison ivy, and then you pat your dog, or they come in and they rub themselves against somewhere and the resin can sit there for weeks, then out of season, you could contact poison ivy. And if you're allergic to it, which upwards of 75% of the population is, then you'll react.
I think that's a very important point, how long the resin in poison ivy stays on, on your bike or on your clothing, how long that can stay there if you don't wash it out well. You were going to say something, Dr. De Coven?
I was just about to say, just to make it clear, that we don't test the poison ivy. So I showed you a lot of allergic reactions and a lot of reactions that we can test to. And the reason we don't test the poison ivy is, first of all, a huge percentage of the population in North America, or at least in this part of Canada, is allergic to poison ivy. And if they're not, merely by testing them, we can make them allergic to poison ivy. So poison ivy is a clinical diagnosis taken by history, and then the types of clinical pictures that I showed you, it's not a patch test diagnosis.
Yeah, thank you for pointing that out. I have a question here for Dr. Champagne. Is it possible to continue virtual appointments for dermatology-related concerns? So what is your view on virtual appointments for dermatology? How has that been managed so far?
So I think they're really helpful for triage in some cases to know exactly how bad a skin condition is. I think they're really helpful for following up on stable patients who have, say, severe skin disease or on lots of medications, or a check-in to see how they're doing. Anything that requires any kind of, complex diagnosis, I think in person is still best. It's like there's a lot of room for virtual appointments in order to kind of increase that access and improve the efficiency of healthcare and prevent visits and things like that. But it really does have to be the right patient at the right time.
I completely agree. I think when virtual care started, I think people thought, oh, dermatology, it's very visual. It's probably something very easy to do virtually. But there's so many nuances to skin diseases and skin lesions that you really cannot capture in photos, and especially on webcam, as you pointed out. We also have to take a look at the entire person, right? Like, we cannot take one mole out of context from the entire person. So I think that's what people don't realize, that the reason we still like to see patients, we prefer to see, especially new patients in person, is that we can't just look at one spot and make a call. Like in any medicine, you have to take the entire patient as a whole, take the entire context and do a full skin check and look in places where people don't think of looking themselves, right? And that does help us make a decision.
The other thing is that in pictures, we're looking in 2 dimensions. And so any of us who practice dermatology know that we think at least in 3 dimensions.
Yes.
And part of that is the way the spot feels, what the texture is, whether
Yes.
we can feel something underneath the skin. And as Trevor was mentioning, such instruments as dermoscopy, which we can't do. And the other thing is, having done a lot of teledermatology, is that people just can't take proper pictures. Finally, I've seen situations where someone sent me pictures who I know, I see them live, I compare the picture, which was taken just the other day, and it looks way worse than what they look like in person. So it can either enhance the way you look, or it can actually make you look worse than what the actual rash or lesion is.
Yeah, I completely agree. I'm going to move on to the next question, and I think this is for me. Are topical formulations better for our skin, or is it better to have a diet rich in these vitamins? Should it be a complementary approach? So the way I'm going to answer this is, it's always best to have a complementary approach. I mean, for sure, these vitamins are essential to the function of our body. So nothing beats a balanced diet. And that is really not just for your skin, but for your general health overall. So we talked about, like, let's say for vitamin C, it's for blood health and bone health and all of that. And vitamin D and vitamin A as well is for your sight. So you certainly need these vitamins internally with using a balanced diet. And just because you take vitamin C, a vitamin C supplement, let's say, doesn't necessarily translate into applying vitamin C as an antioxidant on your skin. So it's not the same. Taking a vitamin C pill, let's say, is not the same as putting on vitamin C on your skin. So I think it is better to have a complementary approach, and a balanced diet with all of these essential nutrients is certainly the top priority. You also can't absorb vitamin C internally through your skin. So if you're lacking, let's say, vitamin E, you can't put vitamin D on your skin and absorb that. Okay, this is another question for Dr. De Coven. Is it a good idea at some point in life to have a complete body check for skin issues or allergies, like a screening test for allergies?
We usually find that the predictive value of the tests has to do with what the prevalence is in the population. Meaning, the higher the chance that someone is allergic to something based on their history, the greater the chance that we're going to find something and it's going to mean something. So otherwise, I suppose I would be on Bayview Avenue recruiting people from off the street to come in for me to test them, which would be maybe fun in some sense, but probably would not be of a lot of use for them, especially if they're not having a problem. And my philosophy is, why expose someone to extra testing if they're not having a problem? It's like some people would subscribe to, oh, maybe every 2 years I should have a CT scan and an MRI. But I think most of us would say, well, we're not going to do that unless there's some sort of genetic syndrome that we're looking for that runs in our family, or we're having symptoms where we're looking specifically for a problem.
I have a question for Dr. Champagne. Are there any current apps or AI platforms that you think could be useful for, skin concerns in general?
Truthfully, none that I would endorse.
Okay.
Really
That's good
and
to
truly.
know.
Even again, I won't mention names. Even the biggest offerings that you can think of have incredibly significant problems with the methodology of their studies and kind of their application. So right now, there's nothing I would recommend.
Yeah, that's good to know, because there are still limitations to the technology. And maybe, what do you think about the use of technology for education, let's say, for patients in terms of skin diseases?
Well, I think it's great to have the educational resources available. It's like anything else. You can, if you do a deep enough dive, it can be difficult to sort out the good information from the bad. So you want to pick reputable sites with reputable information. Associations run by dermatologists, essentially, is probably the best place to go for education. But there's tons of educational stuff out there now that was never out there, 10 years ago. It can be tricky to find it.
It's true. I tell my patients, don't read someone's blog. Go to reliable sources of information. I think we've answered a lot of questions tonight. And again, I would like to thank my colleagues for the time and the effort and the generosity of your time and expertise in these talks. Thank you to Sunnybrook for organizing these evenings. I think, patients and our friends in Sunnybrook appreciate this a lot. Thank you to Carol for introducing us and for introducing the evening. And with that, I would like to say good night to everyone. Thank you for your attention. Thank you for your questions. Thank you for making this a fun evening. And Dr. Champagne and Dr. De Coven, thank you again.